It's my privilege to present this year's presidential address. And first of all, I'd like to welcome our distinguished guests and visitors for coming along to support the meeting this year. You're indeed very, very welcome. I thought that in terms of the address that it would be useful to set the context in which BAUS is currently operating, the political landscape in which we're operating, as our practice is becoming increasingly political because of the problems that are going on in the NHS and beyond, particularly with Brexit and with the state of the finances. The NHS was founded in 1948. It was founded on these three core principles: the principle of the delivery of high-quality medicine, the idea that it would be delivered to all citizens, and also on the right there you'll see the basis of professionally judged medical need. And this rapidly transformed into the idea that it would be a comprehensive, free-for-all service at the point of entry. And this has been the principle under which it's been delivered over the past 60 or so years. But what has happened over almost the past decade is that the finances underpinning our ability to deliver care have come under significant stress. And as a country, we are spending less of our GDP on healthcare in terms of trying to deliver that care, and this is posing us a problem. And this is illustrated here as the financial director's perception of the trust position with regard to their ability to provide services. And whereas we can see on the right-hand side of the graph that there's little increased confidence among financial directors in terms of their ability to deliver care, we continue to have significant problems. And we are not investing sufficiently in terms of our ability to deliver services moving forward into the future. So that you can see here tabulated is that almost half of our trust directors expect there to be an overspend of their budget once again in this financial year. Increasingly, patients are spending longer than 4 hours when they attend our accident and emergency departments, and that number has gone up by almost 600,000, in excess of 600,000 in 2016. And because of that, we almost have 250,000 people waiting in excess of 18 weeks for hospital treatment. So the problems are multiplying. So the pressures in relation to the NHS, and particularly the NHS in England, is that there's really no more money or not sufficient money to do what it is we would like to do. The higher costs of treatment, because we know that healthcare costs expand by approximately 4% on an annual basis. We have soaring expectations, not helped by our politicians saying that we can deliver this in relation to patient care. And we have a growing and elderly population. And this is in a world where austerity dominates what's going on. And this is illustrated here in terms of our population time bomb. So on the left there is the figures for 2017 in relation to the United Kingdom and the potential expansion in terms of our population over the next 30 to 40 years. And what we can see is that in the next 5-7 years, in excess of 30% of our population are going to be over the age of 65. And these people will largely not be contributing in terms of taxes, but will be significant receptors of health care. And as we have a gradually aging population, the morbidities, the associated morbidities that people will have will also increase. So the expectation is that at the age of 70, probably 50% of our population will have 2 or more comorbidities. And this is the healthcare scene in which we are currently endeavoring to practice. Now, as a specialty, and indeed the medical profession has benefited in many ways from the changes in staffing of the NHS over the past decade. This slide has come from Dave Shackley, and what we can see here is that the number of consultants in the health service has risen by about 16 to 17% on total. And yet we universally feel in relation to urology, where our expansion has been of the order of approximately 4%, that expansion has not actually been sufficient to meet needs, as I'll be discussing later. Having gone from a situation where the perception was that we were considerably under or over-managed in relation to managers, we can see that we've had a significant decrease in terms of the managers who are trying to bring all this service together. So how does this impinge? Well, it impinges significantly in terms of the sort of strategy that my predecessor, Mark Speakman, put in place during his tenure as president. He was very keen, and we were very keen as trustees, that we would be in a position to try and support urologists in their professional lives to deliver excellent care. First and foremost, BAUS is a charity, and that is its primary aim. We were also keen that BAUS would enhance its status as the leading authority for urology in the UK. And you heard on the first session relating to standards that both the NHS, CQC, etc., are very keen for us to be involved in the development of standards so that we can endeavour to set forth what might be the best mode of care for our patients. Because we live in financially stringent times, we also must evolve to be an effective and efficient organisation. So I'm pleased to say that this coming year we will not be raising your fees. We've kept the fees steady for the past 5 years, and we will not be changing it again this year. But that means that we are operating in a slightly different financial climate, and that curtails some of the things that we would like to do. And urology is undergoing a significant transformation with regard to its demographics and gender. So you can see here at the top of this slide that approximately 4% of our urologists are female, those over the age of 50. But you can see that that scene is rapidly changing. So we know that approximately 58% of medical school graduates are female, and as a consequence, more of our junior trainees are and will continue to be female. And in this year's national selection, I think it's true to say that in excess of 50% of those that were appointed were women. And that is going to make a significant change in the way in which we operate. So our consultant numbers have gone up by approximately 4% over the past decade. And I'm very grateful to Mike Palmer, who runs the survey and gets the information in. He's helped with this. But in addition, because we had a major expansion over the past 20 years, we have a projected consultant retirement going forward to 2021, we estimate in the region of 260, 265. And so you might reasonably ask, are we going to be in a position to actually not only replace those people who are going to retire, but actually get more urologists? Bearing in mind that we have the lowest ratio of urologists in Europe, with the exception of Ireland, at 1 in 65,000 of the population, so quite small numbers. And because of these emerging problems, we have significant issues in terms of manpower and jobs. Our junior colleagues will no longer consider working, I think, in units where there's a 1 in 4 rotation, and they might be poorly supported by an FY1 or an FY2, a junior doctor. So we estimate, more than 100 unfilled posts nationally. We have creeping or accelerated centralization. So it's no surprise that colleagues would wish to work in a larger unit where they can develop a subspecialty practice and be on call on a 1 in 12, 1 in 18. That seems attractive to me, doing something significantly less. The more we subspecialize, then we're leaving more on the fringes. And that has implications in terms of people who wish, in terms of a DGH setting, to develop some form of subspecialty practice. As I indicated, many of our colleagues in DGHs feel somewhat undersupported and overwhelmed by what's going on, particularly in relation to the on-call arrangements. And you can see here in the graph on the slide on the right there, that in terms of teaching hospitals, most teaching hospitals will have a fully substantial mid-grade cover at night, but the same is not true of a DGH. And this is a problem. So the longer-term projections in relation to consultant numbers, and listed here as the medium requirement scenario, is that if we expect a modest expansion, and a modest expansion is approximately 2% per annum, the estimate is that we may be actually 200 urologists short over the next 12 years. So indeed a problem. So what are we doing about it? Well, I'm going to take you back for a moment just to talk about the National Training Survey. So this is the survey that's led by the GMC. in relation to how medical students and junior doctors get on. And it's unfortunate that surgery and emergency medicine and gynecology rank the lowest in terms of the experience of our young doctors when they come out. Up to 10% were being asked to cope with things that they felt was beyond their remit and they weren't properly supported. So foundation surgery has the lowest satisfaction rating of all the disciplines that our juniors are exposed to. So if they are having a bad experience, they are less likely to consider surgery as an option. If we're not fishing in this pool, we are then unlikely to attract the urologists of the future. So what's happening to our junior doctors? Well, on the right you can see that unfortunately our junior doctors have become somewhat disenfranchised over the last few years. They're working jolly hard, they've had new pain conditions, and we estimate, or this isn't my figure, this comes from the Foundation Programme Committee, and they estimate that upwards of almost 50% of juniors are being lost to medicine within a year or two of actually qualifying. We don't know what happens, but a proportion of those will certainly come back in. We continue to be attractive as a specialty, but only relatively attractive as a specialty. So our competition ratios in relation to encouraging trainees to join us has gone down over the last few years. So our competition ratio is now in the region of 3-to-1. And we're fortunate in that we were able to appoint to all of our training posts this particular year. But unless we enthuse our junior colleagues, unless we enthuse our medical students to consider a career in urology, that may no longer be the case. So we need to do more. We cannot assume that people will simply be attracted by the specialty. Remember that in relation to the undergraduate medical curriculum, urology is poorly represented. There are 31, 32 medical schools, 31, 32 different curricula, and for many, urology gets very little mention. You cannot be what you cannot see. So for this reason, we have put a lot of effort into trying to bolster that. So the general practice lessons in relation for urology, and general practice recruits, it doesn't recruit enough, but it recruits over 3,000 new trainees a year, are issues around work flexibility. As we change our demographic, understanding the need to take time off to have a family, or indeed to care for relatives, or indeed to do part-time work. Dispelling some of the macho perception in relation to surgery and urology. And here I might stand alone, but I think that run-through training is potentially attractive to trainees. I know that the SAC don't agree with that and would rather see selection later on. But geography trumps specialty at the moment, or so it appears. People want a little certainty at a time in their lives in terms of where they're going to train, and perhaps secondarily is what they're going to train in. And ultimately, we need positive role models. We need role models from everybody in this audience in order to enthuse the next generation coming through. So for us as an organization, I was very fortunate to be asked by Adrian Joyce to be the first director of the Education Committee, and since then Andrew Dickinson has taken over. And because this role has grown, we have now a committee sitting underneath Dickie, and we have a lead for medical students, our core trainees and our SPRs, and I'm hugely grateful for all the work that has been done. So endeavoring to develop medical school champions, using essay competitions, anything to raise the profile of the specialty. And one of the things that we will be looking at is actually look at BAUS membership, not only for trainees, but also for medical students and for core trainees. With respect to the core trainees, we're having a symposium later on, which will be led by Dominic Hodgson. We've pioneered some sponsored membership to bring people into the organization and to raise its profile, and of course developing core courses. And Owen Hughes has latterly taken on the role then in relation to the development of the revision and the management courses. Hugely important in terms of CME. Now, it is unlikely that we are going to get an increase in the number of trainees. We would like an increase in the number of trainees, but it is unlikely that we're going to get that over the next few years. And steering this ship, any decisions we make, those decisions will only come to fruition a number of years down the way. But what is happening is the development of a physician's associate workforce. And currently it's estimated that there are approximately 350 physicians associates working in acute hospital trusts across the country, but very few in urology. I can name only one or two. And so you can see on the picture there, almost every medical school has now started a physician associate program. And under the aegis of Dicky and of Ian Pearce, we have developed a urology syllabus and a curriculum for physicians associates with the aim of attracting them into the specialty, because we will need to get them to help in terms of delivering some of this work. And as part of their remit, we'll be developing courses and boot camps, and in due course, probably considering membership as well. Now, this changes what it is that we are doing, those of us who are consultants in the audience, so that we are now working in a completely different way to what it is we did a number of years ago. So not only will we be responsible for our other medical staff, but by default, we're also responsible in many ways for our nursing colleagues, and the precise regulatory framework for the physicians associates has yet to go through Parliament and to be worked out. So we're practicing and continuing to practice in a changing world. So the role that I came into as a consultant when I was appointed to Salford back in 1993 is very different. We have increasing patient expectations and pressures. We have the involvement of job plans and appraisals and revalidation with the GMC, a requirement to partake in audits and the consultant outcome publications. We have significant management issues. Management has got increasingly complex. The delivery of care has got increasingly complex. I can no longer assume on a Thursday morning when I wish to operate that there are going to be beds. I spend an inordinate amount of time trying to sort out those issues. And then we have an emerging education and training issues in terms of trying to ensure that our colleagues continue to develop and need to be supported. All change. And so it's no wonder that many people are feeling that this is all a bit much and that there is an element of burnout in the profession. Pictured here on the right is a picture that I took of a poster at the AUA. I was interested to see because we had published on this a couple of years ago under John Thornhill. And the results from the AUA, this is awarded a best poster, is that approximately 42% of American urologists are feeling similar problems, are experiencing symptoms of burnout. So it's for this reason that we're having a session this afternoon entitled When Things aren't going well, here in the Lomond Auditorium beginning at 1:45. I'd urge you to come along. The single most important thing that we've been asked over the past decade, I think, are questions in relation to job planning. And it's for this reason that we published a job planning document in autumn of last year. And this went through many phases, discussed among trustees and councils, because we were conscious of the fact that at the coalface, many people were having problems in terms of expectations around them and what they might develop. Remember, careers are going to last increasingly, and there's the expectation now nationally that people are going to be working well into their 60s, which wasn't the case a little while ago. So the purpose of this was to give some guidance around direct clinical care and expectations with regard to professional activities, external duties, and the list that you can see there. Now, I don't expect you to read this slide, but if we just look at the top in terms of new outpatient visits, in this is some recommendations for consultant activity based on 1 PA. So the idea of a 1 PA in England is that of a 4-hour session. And I know when I've shown this to many colleagues, they have laughed and said this is utterly ridiculous, the idea that you would only see 11 patients during a session. Well, I would counter that by saying that if 11 patients are being seen and having a good experience, being properly triaged, having the right investigations, and then going out and perhaps not being seen again, that might be time very well spent indeed. And not only that, but that might be sustainable over a long period of time. To my mind, the era of these enormous clinics, which we wear with a badge of pride, that we saw 25, 35, 40 patients, they should be consigned, I think, to the dustbin of history. As I've said, I think urologists are going to work differently in the future. Broadly speaking, we work a 42-week year. There are 52 weeks in the year, allowing for study leave, allowing for holidays, etc., bank holidays. We work approximately 42 weeks. And with a changing population of urologists emerging, our urological colleagues may wish to work in slightly different ways. So in this document is some advice about how that can be done, recognizing that a 12 PA contract will amount to approximately 504 sessions over a year, but they may be concentrated at particular times, allowing an individual perhaps to be away from the cold face when they need to be with family around Christmas time, holidays, etc. Now, in relation to what's going on, the reason that we have been able to punch above our weight, I think, as an association, is that we have had very good manpower data. And what I would say to you is that data trumps anecdote. So it's really important that if you haven't already completed the workforce survey, we would dearly like you to do so. We would like to get that number up well beyond 500. We have over 900 consultant members, but we're keen to hear from all of you. One of the significant triumphs, I think, over the last few years has been the development and the improvement in the BAUS website, led by Nigel, that you can see here in the corner. So we had 1,600,000 page views in the year from May 2016 to 2017. So that's approximately 140,000 page views per month. And when you look to see who is going there, a lot of this is happening in relation to patient care. So in a month, almost 40,000 page views in relation to diagnostic. I think I might have particular things. In relation to surgical outcomes, there is clearly an interest in this. If it isn't that we're looking at our colleagues' data to see what it is they're up to, or perhaps our patients to see where it is that they should go to have a particular procedure. And a fantastic bit of work is on the verge of being completed, that we have uploaded almost 160 new patient information leaflets. These 160 relate to largely to surgical operations and have represented an enormous amount of work done by the various sections. It has taken a lot of blood, sweat, and tears, but we're on the verge of getting there. And on the right, the bottom right, you will see some of the information. We have a small information card that you can pick up from the BAUS stall. You may wish to take that away, get it copied, and develop your own things to give to patients so that they can access the website and get information. And I think even David Spiegelhalter would be happy-ish with the way in which we have presented the information. So we've worked very hard to present it in a clear, coherent way. So much so that the AU are now expressing some interest in terms of taking it on board. The relationship between BAUS and BJUI goes back many years, and Krishna and I have had a number of talks in terms of cementing that relationship going forward. And I'm pretty confident that we will shortly arrive at an arrangement whereby the journal moving forward will be inextricably linked with the BJUI knowledge. And I think this is a fantastic initiative and I hope it goes well. And I think as our juniors come up, they will increasingly use BJUI as a source of information. Ian Pearce has led the Journal of Clinical Urology with distinction over the past few years, and I think he's done a fantastic job in terms of raising the quality of the publication. This time last year, Mark spoke about the section review that was being headed by Malcolm Lucas. We had approximately 17% of the membership responded, but as a consequence of that, we took the initiative forward and had a section review meeting in February of this year, and subsequently debated the outcome of that with trustees and council in April. And in principle, there was no clear consensus about the formation of a section of general urology. But what there was, a broad consensus, was that urologists really should be better supported, particularly those doing core work. And we would like to be in a position to better support them in their work at the coalface. And in terms of taking this forward, I'll be convening a meeting of regional council representatives to discuss this in more detail in early September. You heard from Mike Zeideman this morning in relation to CQC, Care Quality Commission, and its development of standards. Now, BAUS is an outlier in relation to our consultant outcome publication. The reason we're an outlier is that we spend a disproportionate amount of our money, we spend a disproportionate amount of your money on the development of the various audits. So it currently costs us a lot. And all this work is fed into the consultant outcome publications. And there's only one national audit that's properly funded at present, which is the National Prostate Cancer Audit. With regard to CQC, as you heard from Mike, and I don't need to reiterate this, they're very keen that they would develop new metrics. And they would like to work, and Mike in particular would like to work with us in terms of a partnership to develop what those metrics might be in terms of an emerging standard. So we had a vote here this morning, and of the audience that participated, 60% or so felt that standards were appropriate. I think there's a cogent argument to be made that with standards, we gradually endeavour to raise the level of care. So this is one activity or another activity that we'll be moving forward with the sections over the next 12 months. As part of that, I have initiated a data and audit review, because I think there's some pertinent questions we need to ask ourselves, having been in the data and audit business for almost 15 years. So what is the data at the moment telling us about quality and quality improvement? I went to the Baggers meeting on Monday morning at 8 o'clock, and Tony Mundy was regaling us with some of the statistics from the audit, which seemed to be new to a number of the people in the audience. So we're not terribly good at actually disseminating some of the data. Is it really changing our practice and improving quality? I remain unsure. Could our program be developed more efficiently and effectively? I think it could. And finally, we have significant issues with regard to the primacy of data and the privacy of data with regard to Section 251. So we'll need to move forward with that over the next year, and that's why we're conducting this review. Mark told you last year that Project 2020 was ongoing. This is the project to develop the college. This is now definitely going ahead. BAUS have agreed in principle that we're going to stay with the college, so that we're going to move into the Barry building there on your left. But as yet, we haven't had to sign any lease or any termination of our agreement. But this will doubtless happen over the next few months. I'm particularly proud of the work that BAUS does abroad. And pictured here, the urethroplasty team, there's Susie Venn, you'll recognize other colleagues. And this work is hugely important, and we're delighted that we have been able to cooperate with our partners, with TUF and BJUI, in terms of some of the activities that are going along. And you can see there that there are 3 sites that teams have been out to over the past years, and we continue to develop and move forward with those links. Very important for the patients that they serve, also important for us in terms of understanding what's going on, and sometimes for our trainees as well. One of the great pleasures about being a president is your ability to hand out gongs to worthy people. And you can see here that this is Rob Pickard on the right. Rob, as many of you know, has been unwell and took premature retirement from the association, but he's here this week, which we're delighted about. So it's a real privilege to present him with the St. Peter's Medal last November up in Newcastle. Now, all of what I've said to you would not be possible without a big team working around me. So you can see here pictures of the trustees. I won't go into names, addresses, and details, but I'm hugely grateful for all the work that they have put in, supporting me, occasionally calling me to task, and I've just been hugely fortunate in that. And sitting behind the trustees is the council and the section leads. These individuals put in a huge amount of time and effort, frequently unrewarded and unrecognized, but I'd like to pay tribute to them in terms of all that they do, really on behalf of you and the association. But in the office, then we have the A team. So probably not a day goes by during the working week when I'm not in contact with members of the team. And they continue to provide unstinted, loyal service, working terribly hard, enabling us to perform, I think, exceptionally well for an organization. So moving forward, because we mustn't rest on any of our laurels, what are our priorities for the coming year? Well, we need to continue to support urologists to deliver optimal care, okay, both home and abroad, and we'll be working on that. Hugely important that you fill out the workforce survey so we can take the temperature of what's going on in these islands at the moment. We need to commission a new CRM resource later this year. That's actually quite a bit of work because that relates to our relationship with you in terms of the association and how we make that work in a financial term. The size of the annual meetings continues to decrease a little, so the amount of money that we make from the meetings continues to decrease. We need to husband our resources carefully. We need to have a strategic review of our data and audit work, and hopefully we'll be coming back to you. And as I indicated, we need to expand the membership moving forward. And trustees and council will be looking at that in some detail. So I'd like to thank you for all your hard work, for being here, supporting the meeting, and I hope that you have a great time over the next day or so. Thank you. So, as I indicated earlier, one of the great pleasures of being president is that you get the opportunity to recognize individuals who have given outstanding service to the organization. And the first we're going to do today is the St. Paul's Medal. And this medal is awarded by BAUS Council to honor distinguished colleagues from overseas whose contribution to BAUS, or urology in general, is universally acknowledged. And Richard Turner Warwick, who was president between 1988 and 1990, presented the association with a die for the medal in 1989. I'm delighted to say that this year's recipient is Professor Anthony Costello from the Royal Melbourne Hospital, and the citation will be done by Ben Challencombe. Ben.
Mr. President, ladies and gentlemen, thank you for the honour of reading this, and I'm grateful to my friend and colleague Declan Murphy for his help with the citation. Professor Anthony Costello, Tony to his many friends and colleagues, is one of the true statesmen in the world of urology, excelling as a clinician, scientist, teacher, and surgeon. His achievements and contributions have led to huge changes in the practice of urology in the UK and overseas, to the great benefit of all of our patients. He is internationally recognised and is the only Australian to be elected to the American Association of Genitourinary Surgeons, whose invited membership is restricted to the top 75 urologists who've demonstrated outstanding leadership in the field of urology internationally. In 2015, he was recognised by the people of Australia when he was awarded Member of the Order of Australia for significant service to medicine in the field of urology as clinician, administrator, and author, to cancer research and to medical education. To highlight a few of his many achievements, Tony is particularly regarded for his work in benign prostatic hyperplasia. His landmark scientific thesis, randomized controlled trial, and peer-reviewed publications on the use of laser surgery for men with benign prostatic enlargement has led to great progress in minimally invasive surgery in this area. Anatomy of the prostate. Tony has created a passion for anatomy and has published some of the most cited scientific papers in prostate anatomy over the last 10 years. In the anatomy laboratories of the University of Melbourne, where he and his team have performed meticulous dissections to better understand the complex anatomy of the nerves and structures surrounding the prostate, thereby helping us plan better surgery to reduce side effects. Robotic surgery, of course. Tony recognised before all others in Australia that robotic-assisted surgery would play a major part in the advancement of outcomes for men undergoing surgery for prostate cancer. He performed the first radical prostatectomy in Australia in 2003 and has trained a generation of surgeons to perform this surgery safely ever since. As a result, like the UK, robotic surgery is now the most commonly performed surgical technique for prostate cancer in Australia. Fellowship training. Tony has overseen one of the world's top fellowship training programs in GU oncology and robotic surgery over the past 15 years. He's trained over 45 fellows from all over the world, many of whom have gone on to develop robotic surgery programs in their own countries and to become leaders in the field themselves. His links to BAUS are particularly strong, as he's hosted many BAUS members on the fellowship program in recent years. For instance, myself, Robin Weston, Paul Cathcart, Tom Walton, Tim Lana, Owen Cole, Harbinder Sharma, and currently Raj Nair. Tony's authored over 200 peer-reviewed publications, many book chapters, and been an invited speaker 75 times in many countries around the world. He's raised over $35 million, Australian dollars, in competitive grants and philanthropy over the last 10 years, the majority of which is dedicated to men's health. Similar to our own 10,000 Genome Project, but preceding it, over the past decade, he's amassed over 1,500 well-annotated prostate biobank tissues, and his department at the Royal Melbourne Hospital has been appointed as one of the International Cancer Genome Consortium centres. And finally, conference organisation. The Asia-Pacific Prostate Cancer Congress is the biggest prostate cancer event in the region of Asia, attracts 1,000 delegates a year, and is in its 17th successful year. However, despite all these wonderful achievements, which have led him to be the highly respected, internationally regarded surgeon which he is, his greatest legacy is likely to be the team he's formed around him to continue his pioneering work. As Director of Urology at the Royal Melbourne Hospital, he's recruited and inspired a highly talented and diverse group of specialists with a strong interest in research, training, and education. He's created a culture of excellence and ambition, which is of international renown and has led to world-class clinical service. Professor Anthony Costello, Tony, my mentor, my friend, congratulations on this richly deserved award of the BAUS St Paul's Medal 2017.
So the final award this morning is that of the John Anderson Award. John is a former vice president of the association and unfortunately died untimely of prostate cancer a couple of years ago. And this award is named in his honor. And the criteria were a little unusual in that we had a number of different criteria that John and his family put together. Category 1 was a single event of critical importance to a patient or urological community as a whole. Our Category 2 was an individual who's contributed to urology in an outstanding or inspirational way. Our Category 3, a commitment consistent with high quality care, something that John was absolutely passionate about and could be demonstrated in a number of different ways. A number of previous award holders have been Krishna Naharaya, Ben Gray, and last year Ans Khan. And this year's recipient is Mr. Ben Eddy. So Ben is a consultant urologist at Kent and Canterbury Hospital and also a senior lecturer at Canterbury Christchurch University, having trained in the South Thames region. He completed his fellowship training in robotic and laparoscopic surgery in Adelaide in Australia in 2008-2009 and subsequently came back to the UK. He spent a year in Southmead and then he took up a substantive post in Canterbury. And with the support of his colleagues, set up one of the country's first post-fellowship robotic programs, now established as one of the highest UK volume centres. And the ethos behind this has been safe clinical implementation with a strong emphasis on clinical governance. Complete report of outcomes, which we like, and maximizing outcomes in all areas. Ben currently performs approximately 150 cases a year, and to date has performed over 1,000 radical prostatectomies. But that's not really the reason behind that. That's some of it. Ben is a fantastic and very keen teacher, and it was clear in terms of the testimonials that received that he is widely acknowledged as such. He's an educational supervisor to KSS trainees, national proctor in relation to the development of robotic prostatectomy. And he has developed a successful robotic fellowship based on these principles. As part of that, he was one of the early people to develop from the Urology Foundation's team preceptorship program, and that led to a clinical visit to the Vanderbilt University under the care of Joseph Smith. And as a consequence of that and the emerging relationship with TUF, Ben has organized and participated in a number of cycle events and has just completed a TUF cycle to Amsterdam. As part of his next outing, he's currently looking at the development of support for a transatlantic row as part of the extraordinary Tazagur Transatlantic Challenge. Ben is married to Ali and has had huge support in terms of developing his career. And despite having 3 children, spends an inordinate amount of time in terms of his educational and his clinical activities. So I'd like to ask Ben to come forward as a worthy recipient.
Thank you very much.